Next to speak is Mrs. Shannon Seymour, clinical psychologist and director at the Wellness Center, who will be discussing expanding our understanding of adverse childhood experiences, examining intergenerational trauma in the Caribbean context. Please join me in welcoming Shannon.
I promised my staff dinner if they would stay and listen to me. Thank you to the Alex Panton Foundation for this wonderful symposium. It's hard to believe it's been 6 years already. We're going to go on a journey for the next 20 minutes. I'm going to watch the clock. We're going to look at what we understand about ACEs, and I know we've heard a lot about them already, and we're going to look at them from a slightly different perspective and see if we can maybe expand our understanding of them. We're going to look at what the science tells us about epigenetics and intergenerational trauma, and then what kind of evidence there is that talks to the Caribbean or the Cayman context. So we're going to go on this kind of journey through the data and what the data tells us and the research tells us over the last 30 years. And you'll see at the beginning is the ACE study, which was published originally in 1998, and you can tell by the contents today how often it's mentioned, how prominent it is in all of the presentations that you've heard today, that it was really a pivotal hallmark piece of research that sort of shifted the way we understood adversities that children faced. So the Adverse Childhood Experience Study, who's heard of it? You've all heard of it unless you've been sleeping all day. It originally took place in 1995 to 1997. It was a CDC, Kaiser Permanente, public health initiative. It was never really meant to be specifically related to trauma. It was never really meant to be this impactful in the field of psychology. It was meant to understand what might be ways to prevent and better deliver health care. So it was intended to be kind of that study which would identify risk factors or protective factors for the development of disease and illness. They had 16,000 participants from Southern California who came to a clinic or primary care physician, and they gave them a survey to fill out. I think it was mail. This was back 30 years ago. We mailed things in. And it asked them questions about difficult experiences that they had had before the age of 18, and then their current health behaviors and their current medical situation. And the results really changed the way we think about child adversity as it relates to education, Dr. Stephanie's presentation, psychiatry, Dr. Davis's presentation, healthcare. It really was an impactful study. Now, we've all seen this. I think a couple of people have had this in their presentation. These are the original ACEs that were looked at in the ACE study. They were categorized between 3 core areas: abuse, neglect, and household dysfunction. They primarily looked at things that a child might experience within their home environment. And so what did we learn from this study? We learned that ACEs are very common. Like it or not, life is hard at some point for most of us. We're all going to face some adversity. They found that 2/3 of participants had at least one ACE. And I think if we put our hands up, we could probably all agree that there's a lot of us in this room have faced similar adversities. They found that 1 in 5 reported 3 or more, and that participants with 4 or more ACEs were at higher risk for alcoholism, substance abuse, suicide, mental health. And these are the things that we've heard as reoccurring themes throughout the day, that the more difficulty or the more adversity a child faces, the more at risk they are for these things. This was the original ACE pyramid. Who's seen this? Most people? This is the original one from Dr. Folletti's paper that was in I believe it was in American Journal of Preventive Medicine. And it sort of built this idea that there are these foundational experiences that we have in those very early years of childhood. Although they did ask in this study before the age of 18. So it wasn't really a study that looked specifically at that sort of early developmental brain period, it was asking, did you experience any of these things before the age of 17? The thing that it did was it connected that bottom line of adverse experiences to these health behaviors that we know put people at risk for greater health difficulties. There was a hypothesis at the time that this sort of social, emotional, cognitive difficulty fit in there, but they didn't have the research that we now have to sort of understand what that was. That was often referred to as the research gap in the ACE pyramid, in that we were making an assumption for many, many years as to what might be actually causing it. So we knew the relationship, we knew the more ACEs, the more health risk behaviors, the more disease and illness, the earlier death. But it was the why, or the how is this happening, that was missing. At the exact same time that the ACE study was published, there was this amazing book. And if you're interested in trauma, if this is your thing you like to study, then I would recommend that this book is on your shelf. It is a collection of research up until 1998 that looks at sort of all sorts of global, humanitarian, regional catastrophes, horrific things, and it sort of maps out what the research was related to each of those types of trauma. So it goes through Holocaust survivors, people that spent time in Japanese internment camps, Aboriginal studies in Canada and Australia, things like the transatlantic slave trade. I found it interesting, infectious and life-threatening diseases, and I bet if they put out a new publication of this book, we'd have articles in there about COVID. And so it really was this kind of culmination up until that point of everything that had been written. And at the very end of the book was this small chapter with 2 studies. And this really, it was called the Biology of Intergenerational Trauma. And there was 2 studies in this chapter that really is what most people consider the beginning of sort of our epigenetics, our understanding of intergenerational trauma. That there is something environmental about trauma and exposure, but there's also something biological that is happening. The first study, the animal study, was conducted by a Canadian psychiatrist. I'm going to say his name wrong, Hans Selye. He looked at removal of mice from caregivers and putting them back in and the kind of dysfunction that they had in terms of their ability to go through a maze. There was also another really interesting study by a psychiatrist from New York named Dr. Rachel Yehuda looking at Holocaust survivors and their offspring. And so these were sort of 2 what we would probably call seminal studies that really sort of helped us to start to look beyond just the experiences, but what was happening biologically when those experiences were happening. Dr. Yehuda's study is often sort of referred to as one of the original or the origins of epigenetics, and I'll talk in a little bit about what that word means, epigenetics. She studied 19 Holocaust survivor offsprings, so the children of people that had survived the Holocaust. What she found was she compared them to another group of people that weren't the children of Holocaust survivors, but were still from the same Jewish community in New York City. And what she found was that the Holocaust survivor offsprings had a higher level of PTSD, even though they did not have a higher level of trauma exposure. They hadn't experienced any more ACEs than the control group, but yet they were diagnosed, they had more symptoms and more of a presentation of PTSD than the control group. It was a small sample. That's never good to make big definitive decisions. There was also some people that said, of course, the group of survivors' children would have more PTSD. They've been hearing about these stories of the Holocaust their entire lives. The Dr. Davis's point about that exposure of hearing stories over and over and over again, that I thought was really interesting because I hadn't thought of it in the context of Cayman, about how we retell difficult stories. Nonetheless, it was published, it became quite, garnered a lot of attention. People started to want to understand this, and it really became the starting point of the field of epigenetics. And what is epigenetics? I'm not going to explain that picture. I just put it up there so It would look like I know what I'm talking about. Epigenetics is the study of how behavior and our environment can cause changes in our DNA expression. Not in our DNA makeup, it's not changing our genetic makeup, but the changes are in the way in which our genes are read, the way in which our genes are expressed. And so there might be a gene for a particular trait, and because of something environmental and something biological, it's expressed in a different way. And if there's anybody here that's going off to study, this is a great area to start to get into. I think it's going to give us so much information in terms of treatment, prevention, and being able to identify risk factors. So as science started to develop the ability to measure epigenetic changes, to understand what was happening in the body and in our DNA and in our genetics around these issues of exposure, Dr. Yahalda went back and wanted to do another study. And this time, she got a bigger sample size. And this time what she did was not only looking at the expression, so behaviors or a symptom checklist of PTSD, but she also looked at cortisol levels. And what she found was that the group of offspring had much significantly lower cortisol levels than the control group. What does this mean? We've heard about cortisol, and we've heard about the brain and the fight, flight, freeze, and the HPA axis. And we'll talk a little bit about it in the next couple of slides. But what this really indicated was that there was some significant differences between these two groups, not just in their expressive symptoms, but now actually in something biological, in their cortisol levels. Now again, critics, right? That's what good science is. You publish something and then somebody criticizes it. That's how we move forward in the world of science and medicine and psychology and psychiatry. And people were asking, well, how do you know that their cortisol levels weren't always low? And that this didn't maybe have anything to do with having been exposed to the Holocaust? We'll come to that answer in a minute, but I want to just pause for a little bit to understand what cortisol is, because I think this is a really important piece. To understand epigenetics and trauma in particular, we have to understand cortisol and the HPA axis, which a lot of people have done a great job of explaining here today. Cortisol is a steroid that is produced and released by your adrenal glands, which is an endocrine gland just at the very top of your kidney. Little arrows pointing it. One of the main roles of cortisol is to help respond to stress. It helps regulate our ability to cope with stress when we sense it. So there's this incoming stressor, and cortisol is heavily involved in how we respond to it. So what does cortisol do? In response to stress, biological systems are activated. That fight, flight, freeze, fawn, right? In order to allow our body to kind of activate to fight this stress, to activate to be able to respond to it. During the stress, the brain signals a pituitary gland to release cortisol, and what cortisol does is it's actually involved in kind of the regulation of the HPA axis. And I've got something up here. It says cortisol is the anti-stress hormone. And I know some of my colleagues are like, wait, we always think of cortisol as the stress hormone. You're saying it's the anti-stress hormone. What's going on? Well, I think it's because the same thing that we talked about with Dr. Stephanie is that really tiny window of tolerance. Cortisol is really important in the regulation and balance of our stress response. Too much is bad, too little is equally bad. It's not one of those things like where more is bad, so we want less. It doesn't work like that. We need enough to kick in that stress response action so we can respond to the stressor, we can pull off the highway when we're sliding, but not so much that we stay stuck in that activated state and are unable to regulate ourselves. Without cortisol, our body actually can't turn off an activated stress response. Too much cortisol, and it keeps the loop going. This is a great graphic that sort of shows how it flows through. You've got your hypothalamus, your pituitary gland, there's the threat. There's whether it's an experienced threat in our traumatized kids, sometimes it's the look on somebody's face, like Dr. Stephanie said, sometimes it's the tone in somebody's voice, sometimes it's a real threat of somebody coming in your bedroom door at night. The stress hormones are activated, your heart rate is pumping, your blood is flowing, your muscles getting lots of oxygen-rich blood, your digestion's turning off because you don't need to be digesting when you're trying to fight for your life. And then cortisol is released to kind of go, okay, where are we at? Can we slow this thing down, or do we need to keep this going? Is this threat still here, or are we safe now, and can I turn this all off? So the balance of this is incredibly important. And it's why cortisol studies have been so involved and so important to our understanding of epigenetics. What's bad about low level of cortisol? If high levels is bad and it causes all kinds of difficulty, psychological distress, not much good medically from really high cortisol levels, what's so bad about low levels? Well, low levels can cause things like depression, anxiety, weakened immune system, increased susceptibility to infection, loss of resilience in stressful situations. That's probably the most important one when we're thinking of intergenerational trauma. Brain fog, difficulty focusing, cravings. I think we heard Dr. Lamb talk about cravings. We've heard Dr. Edwards talk about difficulty with focus and control. And if we think about these things that can happen with low cortisol, and we look at the ACE study, we see an awful lot of parallels. So a major study that kind of started to really get a lot of people interested now were the 9/11 infant studies. What happened was, obviously, the 9/11 World Trade Center attacks, they did a study of mothers who had babies shortly after. What they did was they took a large sample of women that were either pregnant during, had direct exposure to the attacks, and they followed them. They took their cortisol levels and the cortisol levels of their babies. And what they found was that in the group of women who would go on to develop PTSD, they and their babies had significantly lower cortisol levels than the group of women who experienced the exact same traumatic event, but yet somehow had the capacity, through resilience, to not develop PTSD symptoms. Their babies didn't have low cortisol, and neither did they. So it was really this study then that kind of put all the critics of the Dr. Yahalda's original study to bed, kind of, because this was not kids that had spent their whole life listening to the stories of the World Trade Center attacks. These were babies. They hadn't watched the replayed videos. They hadn't heard mom retell the story over and over again. They hadn't celebrated the anniversary or gone to the memorial. They hadn't had any of that indirect or secondary exposure. They were just born. So the previous studies had been looking at women and how these epigenetic changes were seen as sort of passed along from women to their infants. There was a study done at Emory University Medical School, Emory University School of Medicine, my apology to Emory. In 2014, and what they did was they wanted to look and see if there was any of these epigenetic pathways that were showing up in men, right? Were the same changes from trauma happening in men, were those changes biological, and were they being passed on to their children without having ever been exposed? And they did this really interesting study where they took mice, and mice are not people, but it's where all science starts, right? And they gave these mice exposure to this smell, a very benign, lovely smell of cherry blossoms and oranges, but they zapped them with a shock. Not nice, but that's what they did. Wasn't my design. And what they found was that they had both a symptom expression of fear, all the things that we've been talking about, the way that traumatized children and adults behave or act, but they also had epigenetic changes. When they looked at that DNA strand and they saw the tightening or the coiling around, they saw the histone tags, right? All of those are indications of an alteration to the way in which this gene is being expressed. They saw those in the mice in their babies. When they saw the biological changes, they also then, when they gave the babies the same smell, they had the same physical or behavioral reactions. So we were able to see that there was both the behavioral or the learned response from the exposure, but also the epigenetics. And really interestingly was that even in their pups, so the second generation now, neither the babies nor the babies' babies had been exposed to the zap. Of course, they didn't spend time with their dad talking about how bad the zap was. They had lived really nice and lovely mice lives, but yet they had the genetic markers of trauma. They had the response to the smell as if their life was in danger, and they had the biological marker in their DNA. And this is really where we are right now in the study of trauma. And this is where we have to continue to go, and we have to continue to understand this. It's led to conversations about intergenerational transmission of trauma. How do we transmit trauma to the next generation? How far back are we transmitting trauma? Where is this coming from? This is a lovely illustration. The credit for it, I tried to see if I could find who that was, but it's a shut down Instagram page now. So we know that there are both exposure or environmental things that impact trauma and the transmission of it. We know that traumatized people have a harder time parenting. We know that they have a harder time regulating their own emotions, which impacts the people that live in the house with them. But we also know now that there are biological changes that increase susceptibility to trauma, that decrease capacity to manage and cope with stress. So how does this relate to the Caribbean? There isn't a lot of research on this in the Caribbean. So we look outside, where Caribbean people have been part of bigger studies in other parts of the world. A 2016 study that was done in France looked at 1,100 mother-child dyads that were presenting at an outpatient mental health clinic. They examined race, regional identity, income, and marital status. And race was the greatest predictor of stress. Black women were at the greatest risk for high stress, and they had the lowest cortisol levels. And among Black women that were in the sample, Afro-Caribbean women that are either born in the Caribbean and had immigrated into France, or women who were born to Caribbean mothers, were at higher risk for low cortisol, higher mental health difficulties than even women from Northern Africa or Arab Africa. So there is something about the Afro-Caribbean experience that is creating susceptibility, that is increasing risk and decreasing capacity to cope with stress. Another study that took place at the University of Michigan looked at 9,285 participants, and what they found was that race was more significant of a predictor of diagnostic severity and response to treatment when compared to income or age. And I think it's striking that it's often a demographic we leave out of all of our research and conversations, but yet around the world, it is proving to be very helpful in understanding risk, understanding vulnerable populations. Race wasn't necessarily a risk factor for a diagnosis, but for severity of the diagnosis and severity of the symptoms, and also response to treatment. And you see the scale there when they compared African Americans to Afro-Caribbean people, and non-Hispanic white people. You see that there is a significant difference in severe generalized anxiety disorder and also in having a diagnosis of PTSD. And this was really interesting. I knew this slide was in my presentation as I was listening to the panel of young people, and I think it was, I don't remember her name, my apologies, who was talking about needing to be strong, right? About wanting to kind of like be strong and needing to be strong. And we often see that. We see that in our Afro-Caribbean culture. This strength is seen as a positive attribute, as a way to deal with stress, right? What it also means, though, is that a lot of times it increases likelihood to seek treatment. It means that it's harder and more difficult, which means we have to remove more barriers and we have to make it easier. If we know that there are particular populations in our community that will find it harder to access treatment, we need to make it easier. More likely to have medical symptoms as their primary trauma response, as their primary stress response. And we know you only have to sit at the healthcare conference once to hear about some of the pretty concerning medical statistics that we have in this very small country. A really big study, a meta-analysis, is something they take all of the studies that have been done, peer-reviewed, good solid design, and they look at them all and they see if there's anything that is consistent amongst all of them. A 2021 meta-analysis that looked at 28 studies found 70% of trauma symptomology outcomes were statistically significantly associated with discrimination. Now, one of the limitations of this study was that they didn't really account for sort of what was the trauma, right? Was it trauma because you were physically abused? Was it trauma because you had heard about trauma? There wasn't a real clear definition, but what they did find was that in this population, that a reporting of discrimination was a significant predictive factor of poor mental health outcomes. And I took the slide out because I was told I needed to make it shorter, but a really interesting study that I can forward if anybody's interested was they looked at having a positive racial identity. It was Rhonda that talked about Addison's difficulty with identity, and maybe it's young people in our community that are struggling with racial identity or national identity or sexual identity. It doesn't matter what it is. If a young person doesn't feel connected positively to who they are, it is a risk factor for mental health. And I just want to big up John Gray, because I loved your Afro Day yesterday, and letting those girls wear their hair is the first step in us encouraging our young people to have a positive identity with who they are. And I kept playing the reel that was on Instagram. My husband was like, "Why are you listening to that again?" I'm like, "I like this." If we turn quickly away from those issues, and I know my time is up, but I'll just talk here briefly. The Caribbean, obviously, we live through hurricanes. As I'm listening to all this trauma, I can think of how many of us sat at the top of a staircase thinking we might drown in 2004. How many kids now are young adults that sat with mommy and daddy with the roofs off or got shipped off to other countries where they didn't know people, right? And we weren't talking about it at that time about being trauma. But if we think about it, we've got a lot of people in this country that lived through a very, very traumatic thing, and we continue to have storms. It's part of where we live. What's interesting is that if you do a Google Scholar or a PubMed search, you're going to find thousands and thousands and thousands of research articles looking at PTSD and hurricanes, looking at anxiety and mental health and hurricanes. And if you try to look for those in the Caribbean, they're very, very limited. We need to do our own research. We need to do research in the Caribbean on Caribbean people so that we can start having plans and interventions and treatment programs that mirror what this data tells us about this culture and our people. Okay, I have 2 slides left. I know it's tempting to interpret epigenetic inheritance as a story of how it sort of creates permanent biological damage. It doesn't. There's lots of hopefulness in this because epigenetic changes can be reversed. All the stuff that everybody's talked about, early intervention, nurturing relationships, making sure that kids are safe and loved on and connected and have a healthy identity with who they are, those can reverse, those can increase cortisol levels back to a healthy place. We also need to revise our understanding of this ACE pyramid. In 2016, the CDC did revise it. They put at the foundation historical trauma. There was enough research around the world to recognize that this wasn't just about what happened in somebody's home. That was important, and it's really, really relevant, but we need to also be thinking, just like we're saying, a couple of people have said it here, it's not about what's wrong with you, it's what happened to you. But I would say, let's take that even a little bit deeper. It's what happened to your people. It's what's happened to those who came before you. And so the same logic applies, that we need to look a little bit deeper when we're looking at the people in our community who are at risk. We also know that social determinants of health play massively into the way in which trauma is transmitted. These are things like poverty, food insecurity, housing, access to medicine. And this is what I love in terms of my understanding of ACEs. Our household ACEs are the tree. We need to work to prevent those. We need laws that keep children safe. We need policies in school. We need all of those things that everybody's talked about. But we also need an understanding that communities can have adversity. And I think Dr. Davis touched on it. One of the original ACE questions, have you ever not had food to eat? That falls under neglect. Maybe mom and dad are poor. Maybe it isn't neglect. Maybe it is inequity. We have to start thinking of things like racism, poverty, food scarcity, lack of economic and social mobility, discrimination, poverty, substandard housing. And in addition, we need to recognize that we live in a part of the world where we are regularly exposed to a threat of death. We are regularly under a hurricane watch or a hurricane warning, and for different people, depending on their experiences, that can trigger a whole lot of emotions and a whole lot of physiological responses. And so I think as we move into a deeper understanding of trauma in our country, I would hope that you would sort of continue to consider all aspects of it. And that the ACE study was where it started, and we're grateful for those researchers, but we really have come so much further past that, and we need to begin to bring that new information into our prevention work, into our treatment work, and into the way that we talk about ACEs. Thank you. No time for questions? Okay.
All right, thank you very much, Shannon, for that very interesting and thought-provoking presentation. We will take a couple of questions from the audience. Again, please raise your hand if you have something to ask, and a mic will run over to you.
Good evening, everyone. I am Dr. Nelson from the Department of Education Services. Thank you, Ms. Seymour, for an excellent presentation. It was very, very insightful, and I really, really learned a lot. It puts into perspective what we see at schools, where we have situations where the trauma isn't necessarily readily visible, but there's a history of it. So thank you for putting things into perspective. When you speak, what came to mind was collective trauma. And where there's collective trauma, there's also collective healing. I'm sorry, I don't have a question, but I have a comment. Mm-hmm. It's extremely, extremely important for us as a society to recognize that collective healing is also possible. It's interesting that an event occurred internationally that sparked persons to be qualified in CPR. Psychological first aid is also readily available. You do not have to be a clinician, you do not have to be an expert in the mental health field to be certified in psychological first aid. So when you have periods where there's adversity, you have hurricanes, persons who are trained in psychological first aid can assist in that collective recovery. So it is possible. I also want to advocate for trauma-informed policies. Now, I listened to my colleague, Dr. Edwards, speak, and we have always been advocating, my team and myself, advocating for trauma-informed policies, especially within the schools. When you have trauma-informed policies, policies that are rooted in trauma, it will take into account things like discipline practices. When you have a disciplinary practice that is not in keeping with trauma, that's when it becomes punitive. A restorative approach is rooted in trauma. And I'm speaking because my research has been in trauma. I'm an expert in trauma among children and adolescents, so that's what I've studied. I'm saying this because I think it's time that we start holding institutions accountable and have them, through their policy, say to us what they have in place to address trauma in their institutions. And it starts within the schools. The trauma-informed school policy will look at things like creating a place of safety for all children. What policies are in place for creating that safe environment? Because it begins with just the infrastructure. It also looks at constant training for staff
Yes.
in their understanding of trauma, and it also looks at the discipline practices, and that's where you can bring in the restorative approaches. I apologize for taking so much time, but I really must run. But I
No,
needed to
thank you
enforce.
very much.
Yes. And I think that obviously by the applause, everybody is in agreement with that. I would also encourage that if you're in the Caribbean, trauma-informed means culturally attuned. And so we can't be trauma-informed if we're not first culturally attuned to where we are. And that goes for whatever region or geographic place that we live.
Okay, we'll take one more question, and then we'll have to wrap up.
Okay.
Is that you, Rhonda?
Thanks, Shannon. That was amazing. I just wanted to ask about the cortisol connection. Is that something that you could test? So if someone is having mental health issues, would you test their cortisol levels? And then what would you do with that result?
I can maybe toss that one to Dr. Davis. I don't believe that it's used in primary care. It's certainly used in research. It has to be collected at multiple points throughout the day. Your cortisol levels rise and fall. They're higher in the morning to get you out of bed, to get you going. They're lower in the evening to kind of settle you into sleep. So it's not just a matter of, I think, showing up at your doctor and doing a cortisol test and letting that have some kind of diagnostic significance. I think we could go there in the future with research. We're definitely not there yet. If Dr. Davis, if you have anything else to add. No? Okay. All right, thank you very much.